Welcome back to Thriving Through Perimenopause. I'm your host, Dr. Anna Glazer, a reproductive and integrative psychiatrist and your guide on this journey to mastering midlife. This is the third part in a six-part video series that focuses on perimenopause, and we're going to speak about biological treatment options for perimenopause. And I'm specifically talking about biological tools because there's so many other tools out there that we'll talk about later, like cognitive behavioral therapy, which has been studied for everything from vasomotor symptoms to anxiety, to exercise and nutrition, and more. In this video, we're going to talk specifically about biological treatment options. To review, in the first video, we really talked about some of the most impactful perimenopausal symptoms and the fact that these often impact our mental and emotional well-being. Things like brain fog, cognitive challenges, mood swings, including depression, anxiety, as well as sleep disturbances, really at the top of the list. We also debunked in that first video the myth of perimenopause as aging and instead thinking about it as a time of transition and mastering midlife. Next, in the second video, we really went over the science behind the psychology of perimenopause, because understanding the science of those hormonal symptoms will allow us to target the perimenopausal symptoms effectively. So we reviewed those hormonal cascades and how they change in perimenopause. Now, let's dive into treatment options. And specifically, I want to start with an understanding that there's basically two directions for treatment. There's symptom-focused, and then there's underlying cause-focused. What do I mean by that? When we're talking about symptom-focused treatment options, if you go back to the first video and you look at that long list of different symptoms of perimenopause, everything from mood swings to dermatological changes to metabolic changes, we can address every single symptom and system of the body individually. So that might be a biological or other kind of tool for managing the anxiety and mood swings. It could be a biological tool or medication for managing the dermatological changes. It could be a medication for managing the metabolic changes. So really looking at each individual symptom and tailoring it to the appropriate system and targeting that. Alternatively, we could think about the underlying cause. The underlying cause of all of these symptoms is the fact that there is this hormonal shift. There's a decrease in the estrogens, the progesterone, the testosterone, and that is what is causing all of these symptoms. So if we replace those, if we replete those, then that is going to treat the root underlying cause. So hormone replacement therapy, also called menopausal hormone therapy or hormone treatment, whichever term you want to use, helps to address that underlying cause. I do like to mention the fact that both directions, both approaches are valid, but not everyone is a candidate for each direction. So really having a thoughtful discussion with your doctor about which direction is going to work best for you. What I want to focus on in this video is the MHT, the menopausal hormone therapy. First of all, what is it? Menopausal hormone therapy seeks to replete those hormones that have come down in perimenopause and during the menopausal transition. So we're talking about usually replacing the estrogen that has gone down, the estradiol specifically, the E2 that we talked about in video 2, the progesterone, and oftentimes the testosterone as well. We often hear the term bioidentical, and there's often some confusion about what that term actually means. When we're talking about bioidentical, we're talking about the fact that the hormones that we are repleting that have gone down are those that are identical in essence in their structure to the ones that the body has naturally previously been able to produce. So that's when we're going back to the E2, the estradiol, as well as the progesterone. Keeping in mind that there's multiple different ways to get those hormones back in the body. The most common is an FDA-approved bioidentical estradiol patch. That is the most common way to replace estrogen because that allows us to go through the system transdermally. You place it on your skin rather than going through the mouth, which means that it's going to have a first pass effect and have to go through liver metabolism, which sometimes can come with a set of risks and potentially side effects. So oftentimes we're talking about the estradiol patch combined with oral progesterone. That's micronized progesterone. Again, it is identical to the progesterone that your body naturally produced in the past and now has decreased levels of. So this combination of estradiol and progesterone. We'll talk more about other alternatives, but those are the most common bioidentical FDA-approved versions of prescription hormone therapy. The next term that sometimes gets confusing is the term compounded. That is a term that refers to the fact that the hormone that you're going to be taking is not the FDA-approved version, that the estradiol and the micronized progesterone that we were just talking about, but one that is created in a pharmacy, a compounding pharmacy. Now, compounding pharmacies have different standards, and I think it's really important to make sure that you're working with a clinician, or if you are the clinician, you're the clinician working with the pharmacy that has a really reputable standard. For example, I often work with a particular compounding pharmacy for some of my patients who might need, let's say, a particularly low dose of a medication, or maybe they need a different formulation. I might want to make a medication liquid instead of a capsule. Whatever the case may be, I am very closely connected and communicating with the pharmacists at this particular pharmacy, and I know their reputation and their standards. That is the challenge of sometimes working with compounded pharmacies, is you need to make sure that it reaches those standards and that you can really feel safe and secure using their products. Generally speaking, the recommendation is to start with the FDA-approved products because those are the ones that the FDA has looked at. They have been approved in terms of the standardized doses and the safety, and those are the ones that we generally want to start with. But again, not everyone is a candidate for that, and we might need to choose a compounded formulation because of this particular dosing or directions for that particular hormone. The next thing I want to really talk about is why there is so much controversy and stigma associated with menopausal hormone therapy. So this is something that I really want to emphasize because this happened several decades ago with the publication of the Women's Health Initiative study. And actually, it wasn't just the publication. The data from the study came out well before the actual publication of the data. It was announced in news media through a press conference, and that really led to a lot of alarm. And it led to a 46% reduction in use of hormonal therapy in the menopausal transition in the United States. That is a huge number, and it really means that so many women no longer had access to this very gold standard type of treatment for their menopausal symptoms. What happened with the Women's Health Initiative study? This was a study that took place and recruited thousands of women into one of 4 categories. The women included in this study either had a uterus and were separated into those who received estrogen and a progestin, or those who did not have a uterus and were separated into groups who either received estrogen or a placebo. The thing to keep in mind is that the estrogen and the progestin were not the bioidentical ones that we use today. And this is a really important point because the hormones that were used were very synthetic and not bioidentical. This is important because, number one, the estrogen was conjugated equine estrogen. They took the urine of pregnant mares and they created a synthetic form of an estrogen. So that's not the same as the estradiol that our bodies make. And the progestin also was not progesterone, the one that our bodies make, but was a different synthetic version of a progestin. So that's an important piece to keep in mind, is that the hormones used in that study were not the bioidentical ones that we're talking about today. The types of hormones that they used were not bioidentical. Point number 1. Number 2, there was a big difference between the age and health of the participants in that study versus the individuals that we think about as ideal candidates for hormone replacement therapy today. So the age and health of those particular participants, a lot of them were more than a decade past menopause, and a number of them were in their older stages. So most of the women were in their 60s, 70s, some even a little bit beyond that. Whereas these days, when we're talking about hormone replacement, we're talking about perimenopause and the menopausal transition, women often in their 40s and 50s. Very different set of risk factors and health. So that's an important distinction, and it makes it a lot harder to be able to take the data from the Women's Health Initiative and to find it usefully applicable to today's population. So the types of hormones is important. The age and health of the participants is important. The next thing I want to mention is this difference between absolute risk and relative risk. One of the reasons that there was this big media surge and a lot of press was because they came out and they said, and this was actually even before they finished all of the statistics, all of the results, and the peer review. So this was before all of that. They actually came out, they said that they were stopping the study because they noticed a 25% increase in the incidence of breast cancer. So that really exploded in the media, understandably. However, the thing to keep in mind is that difference between absolute risk and relative risk. So that means that the absolute risk was actually much, much less than it initially seems when you say those numbers. The difference in absolute risk was the difference between 4 in 1,000 versus 5 in 1,000. The difference between 4 to 5 in 1,000 in terms of incidence of breast cancer. But when you first say it as relative risk, you're talking about a 25% increase, and that's what made it to the news. Unfortunately, the retractions from that initial statement have not made it to the news. So a lot of the researchers in the Women's Health Initiative study have gone on to do additional research, have gone on to do additional data analysis, and have actually tried to better explain the nuances of that data. And unfortunately, it just doesn't make the news as much as that original press conference did. So it's important to recognize that absolute versus relative risk. And so the news media picked it up and said that estrogen causes breast cancer, which it does not, because especially when they did additional studies and looked at the data more carefully, if you looked at the estrogen-only group, remember those individuals who did not have a uterus and therefore did not need to take progesterone, the reason that individuals who still have a uterus need to take progesterone is to make sure that there's no endometrial hyperplasia or any other complications with taking what's called unopposed estrogen. Anyway, in that second group, there was no increased risk at all of breast cancer. And so the thing to keep in mind is that the additional information, the additional research was actually really important, and they cut it short, and there was a lot of early reporting. There was misinterpretation of the statistics. There was a very different type of hormone used. The age and health of the participants do not line up with the age and health of the ideal patients for menopausal hormone therapy these days, which we now say is individuals who are perimenopausal and less than 10 years out from their date of menopause, which, if you recall from the first video, is 12 complete months without a menstrual cycle. So this is a very different use of hormones than what occurred in the Women's Health Initiative study. The interesting thing, the data that didn't make it as much into the news of the Women's Health Initiative study, was all of the benefits of estrogen. So that same study showed that individuals who were taking hormone replacement had lower rates of colon cancer, had improved scores on things like osteopenia and osteoporosis. And we now know that the estrogen also helps with reducing things like metabolic issues. Again, when the estrogen is initiated in perimenopause and within those first 10 years, as opposed to individuals who are 10 plus years out from their experience of menopause, who may no longer be having any symptoms of the menopausal transition and who might be in their 60s and 70s. So it can reduce your risk of cardiovascular challenges, metabolic issues, and cognitive issues later on in life. So it truly is a treatment option that I think needs to be considered strongly by so many individuals. So be sure to talk about menopausal hormone therapy with your OBGYN or your primary care doctor, whomever is working with you around these symptoms, because it really might be a much better fit for you than you otherwise suspected, including having a thorough conversation about the risks and benefits. there's very few absolute contraindications to using hormone therapy. For example, I work with a patient now and she's been taking MHT for years, even though she herself had gone through an incident of breast cancer in the past. And she actually also had a stroke in the past. And she's someone who evaluated the pros and cons and based on the specific kind of treatment that she had, decided that it was an appropriate choice. It matters the type of breast cancer that an individual has, the type of treatment that they receive, all of the different risk factors. So really in-depth conversation that needs to take place between you and your doctor, someone who is certified and trained in treating the menopausal transition and in prescribing menopausal hormone therapy, so they can really educate you about the potential risks and you can make an informed decision. Because again, menopausal hormone therapy is one of the best treatments out there for treating that underlying root cause of the hormone depletion. One question that I often do also get asked is, what about other ways of replacing the hormones? So what about oral contraceptives? This is a not uncommon question, and I do have some patients who prefer to take oral contraceptives when they're going through the early stages of this transition. For example, I'm thinking of one patient, and she really likes the fact that the oral contraceptive has allowed her to have more regular periods again and has taken care of a number of her other symptoms. The thing to keep in mind is, number one, the dosing of the estrogen and progestin in oral contraceptives is oftentimes higher than the dosing that you will find in menopausal hormone therapy because the purpose of those hormones is different. With oral contraceptives, also sometimes called combined oral contraceptives because it's usually an estrogen and a progestin, is to suppress ovulation. So the amount of those hormones needs to be higher than the amount that is needed for managing those perimenopausal symptoms. So if you are someone who was previously sensitive, perhaps, to oral contraceptives, that does not mean that you are not a candidate for menopausal hormone therapy. It's just something to keep in mind. And again, oral contraceptives can be an appropriate treatment tool as well. And then the last appropriate treatment tool that I want to mention is the option of hormonal IUDs. And that sometimes can make a difference in terms of whether or not you're going to be taking, for example, the oral progestin. The hormonal IUDs can take the place of that if the only purpose is, again, to prevent that endometrial hyperplasia, because the IUD will take care of it. Now, the oral progesterone, because it's systemic, as opposed to the localized progestin in the uterus, it can have other helpful benefits. For example, it can help with insomnia and anxiety. The oral micronized progesterone is known to be helpful for both of those things. So even if you have a hormonal IUD in place, you might still also consider taking the oral progesterone. So that's what I wanted to share with you about the menopausal hormone therapy. The other piece that I just want to briefly mention is the fact that nutraceuticals have often been a choice for a number of women out there. And I think there's a couple of reasons for that. One is that some women are still very frightened about menopausal hormone therapy for the reasons that we just went over, for all of the stigma that's out there. The other thing to keep in mind is that nutraceuticals for some people can be a little bit of a gentler way of approaching some of these treatment options. There are a few key points I want to make about nutraceuticals. First is, if you're going to be choosing a nutraceutical, it's really important to think about the source of that supplement. And this is the case for really all supplements. We really want to make sure that the supplements that we're choosing are a good quality brand and third-party tested. So that means that they are tested to ensure that what it says is in the bottle is actually in the bottle at the appropriate dose without any additional toxins. So it looks at both of that, the accuracy of the dosing, as well as to make sure there aren't any toxins, heavy metals, etc. in that particular bottle. So it's really important to make sure that the supplement that you're choosing is from a reputable source. The challenge with a lot of nutraceuticals is the fact that a lot of the studies are very small. There's research challenges that come with nutraceuticals and supplements. A lot of the companies that make them are not incentivized to do large randomized control trials the way that pharmaceutical companies are. And there's also very big differences in the amount of money that's put into developing a pharmaceutical medication versus developing a nutraceutical. So there's definitely differences there. And so it's still important to look for the research, knowing that it's going to be smaller. Research on menopausal hormone therapy has thousands and thousands of women in those studies, whereas a lot of the nutraceuticals might have dozens of women in a study, right? So much smaller studies, but still they're out there, and it's important to find them to make sure that the choice that you're making is evidence-informed. The other piece to really consider is whether it's single ingredient or a formula. And this is something that I discuss with a number of my patients, where we really need to decide if we're going to choose a formula, meaning it's a supplement with multiple different ingredients, or something that is a single ingredient. Most of the studies out there actually focus on single ingredients. For example, there is data out there on maca for some of the sexual challenges that happen postmenopausally. It looks at one ingredient. And part of the reason that's the case is it's a lot easier to study something that is a single ingredient versus a multi-ingredient formula. It's also important to keep in mind if the multi-ingredient formula has something called a proprietary blend, it means that the company is, generally speaking, not disclosing the amount of the different supplement ingredients. And that's really challenging to A, study, and B, be able to make an informed decision about. Whenever I'm working with a patient who's choosing a formula or even a single ingredient nutraceutical, I want to know how much of that particular ingredient is in there. Most of the time with formulas, we have multiple ingredients with a much smaller amount of each ingredient. So we also need to be mindful of the fact that it might not necessarily be the appropriate dosing, right? Because if you're trying to get 5 ingredients into one capsule, you're going to have a lot less of that particular ingredient in that formula as opposed to a single ingredient nutraceutical. So it's important to be really mindful of the formulas versus the single ingredient compounds when you're making that decision. And then the last piece that I want to mention is this idea of hormone influencing versus symptom-specific tools. And this is the same as what we were talking about with the hormone replacement therapy as treating that underlying cause related to the hormone fluctuations and the hormone decrease versus specific symptoms where, again, you can use biological approaches and take an anti-anxiety medicine to treat anxiety. You can take something to treat the metabolic changes. You can take a medication to treat the GI symptoms. You can approach everything individually. You can do that with nutraceuticals as well. You can take a particular nutraceutical that addresses the sexual side effects of the menopausal transition. You can take another nutraceutical that impacts mood swings and anxiety. Or you can look at some of the nutraceuticals out there that really influence hormones more generally speaking. Certain nutraceuticals that have estrogen effects or certain nutraceuticals that kind of influence the system as a whole rather than ones that specifically target a symptom, similar to the prescription tools. And we can certainly talk a little bit more about specific nutraceuticals in future video series, but this is an important point that I want to make, that nutraceuticals can be an option, and it's important that it's an informed option, and that menopausal hormone therapy, the essentially gold standard treatment tool, has also been considered. Finally, I want to mention 2 particular individuals who might be more vulnerable to the hormone treatments. And those are individuals with a history of hormone vulnerability, those with a history of, let's say, postpartum depression, and those with a history of PMDD, premenstrual dysphoric disorder, or PME, which is premenstrual exacerbation of an underlying mental health issue. So these individuals might have more vulnerability to hormone shifts, like those that happen in perimenopause. And I just want you to keep that in mind. If you do have that history, you may find yourself more vulnerable in the perimenopausal transition, and therefore you just want to be more on top of the fact that this is happening and seek out the necessary treatment to be able to stabilize your hormones and get the treatment that you need so that you feel better and, again, can master midlife. So the key takeaway that I want to make from this video is that menopausal hormone therapy is significantly underprescribed because of the Women's Health Initiative, which was an unfortunately interpreted study that came out more than 2 decades ago now, and that truly MHT can really help with so many of the different symptoms of perimenopause and should be considered for everyone well before the official day of menopause. In the next video, we're going to talk about some really specific symptoms of perimenopause that are quite common that can impact mental health. So we're going to do a specific segment on cognitive changes in brain fog, mood and anxiety and mood swings, and sleep difficulties. Stay tuned.